All right, so good morning, and thanks everybody for being here, and thanks Eric for helping facilitate this. My name is Jason from MultiMed Billing, your billing company for your EMS organization over there at Waves, and we're going to go over a topic that nobody likes to go over this morning. We're going to talk about documentation. It's probably the least favorite part of our job, and probably the least favorite thing to go over as far as education, let alone continuing education goes. But I do my best to interject some humor and interject some interactivity in this. So we're going to go ahead and get started. Any questions? Unmute or enter them into the chat roll. I've got the chat window open, as well as if it's a small enough group, or if you want to unmute, go ahead and ask a question. Just so you are aware, this is being recorded at Eric's request, so we can disseminate it to the rest of your organization who may not happen to be on the call today. So a couple of objectives. What really are we looking to get done today? First, we want to talk about documenting all of the good clinical care that you folks do every single day, and making sure that we're compliant. And we're going to talk about compliance in a lot more detail in a little bit, but that's not necessarily compliant with protocol. That's what we think of most of the time when we're talking about compliance with in anything EMS. In the world of documentation and billing, we need to worry about compliance with billing rules, and privacy and laws with Medicaid and Medicare and things like that. Question from Mike Conley. Medicare number affect billing for does an old Medicare number affect billing for a Medicare patient? Most often not. We do have a way to cross-reference those. Good question. We also want to document. Want to talk about documenting operational information, demographics, things like that, and we're going to talk about why that's important. Another objective is all the important information needed for getting you guys paid for the good work that you do every day. And the last objective is for you guys to laugh a little bit. So we're going to start this off with a little bit of documentation humor before we go too much farther. All right, so just a little bit of humor at the expense of other people's errors to start this off with. If you can try to avoid ending up on a future episode of that YouTube video, that'd be a good thing. The thing I failed to mention when I started my introduction is I'm still an active paramedic. I'm still out there doing this job on a part-time basis. My full-time commitment is to MultiMed, but I still do work on a paramedic fly car service up in Wayne County, New York. Matter of fact, I did a shift yesterday. Didn't do anything, but I did a shift. So I'm right there with you guys. I understand some of the frustrations, the protocol changes and all that stuff. So I think we can all agree, before we dive even farther into this, that a PCR, that a patient care report, or documentation of any kind related to caring for a patient is really a timeline of events, right? So regardless of the format that we use, the
Software that we utilize to do our documentation. A patient care report is realistically a timeline of events. So let me back up a slide here and ask a question. When does the call start? When does our call as an EMS provider start?
Dispatch time.
I'd agree with that, probably 80%. The call's actually going to start for documentation purposes at the time the call taker takes the call. All right, now I'm not talking about documenting times in your PCR. The documentation of the actual parts of the call starts when that call for service is received. That call taker determines what the complaint is. It helps us determine what the response is. All right, is it going to be an ALS response? Is it going to be a BLS response? All right, hot or cold. And most places, and I know Onondaga County does, they utilize EMD protocols for their dispatching. All right, so that's the guideline that was used. And depending on your district and your some of your responses in your district, it may determine if it's a emergent or non-emergent response. We're going to talk about the definitions of those here in a minute as well. So the important thing that's going to happen here is the call taker, when they dispatch you guys, is going to assign an EMD code to it, right? So Alpha, Bravo, Charlie, Delta, Echo, something like that. And that's going to be important a little bit later. That's why it's important that this happens at the time that the call for service is received and that it somehow gets to you guys. You'd be amazed at the amount of 911 centers around the state that don't EMD jobs, that they don't assign an EMD code to an EMS response. There's some places that are dispatched by the local police department who has a light duty officer assigned to the desk, and he or she takes the calls for the ambulance and dispatches them in whatever that local municipality happens to be. So you're dispatched and you respond, and you go en route. How'd you respond? That's always a big question. All right, so Medicare has a definition for that. And you're going to see me during this presentation refer to Medicare definitions on a regular basis. The reason for that is Medicare has a big book called the Medicare Guide for Healthcare Reimbursement. And EMS actually has our own chapter in it. It's the smallest chapter in the manual, but we have our own chapter. It's chapter 10. And ground ambulances aren't cool enough to get our own chapter. We share it with paramedical as well. But this is where all the definitions come from. This is where all the rules come from. Now, all of us in the room right now could get together and form a health insurance company. I'm not sure why we'd want to, but we could do it. And to reimburse people, right, to send them a check, we'd have to figure out rules for what we're going to pay and what we're not going to pay. As a health insurance company, why would we do that when Medicare already has all these rules written? So everybody else tends to, for the most part, follow the CMS, or the Center for Medicare and Medicaid Services, rules for reimbursement. And this is a quote right out of chapter 10, and this is the definition of an emergency response. It's the second rectangle here is the definition. An immediate response, they don't even call it an emergent response. An immediate response is when an ambulance provider takes the necessary steps to immediately respond to the request for service. Does it say anything about lights and sirens in there? No, that's not important. Some software companies for documentation have lights and sirens documented in there. It doesn't matter. What matters is an immediate or emergent response is what's documented if you're in fact going on a 911 call or you're taking the steps necessary to immediately respond for the request for service. You know, I know you guys are manned most of the time. If you've got a volunteer service and the pagers go off, you might have a 8-minute time difference from when you're dispatched to when that unit goes en route. But are those volunteers getting in their cars, driving to the station to take the ambulance to the call, taking the steps necessary to respond immediately? Sure they are. Absolutely. So as long as you are doing that, you could bill the call at an emergency level. Now let's go back up to that top rectangle for a moment. It says emergency response is a BLS, ALS1, or ALS2 level of service. What's not listed there that we do all the time, especially now with bumper car season? What do we go on all the time?
Motor vehicle collisions.
Yep. And do we transport them all the time?
Negative.
No. So we get sign-offs, right? What's not listed up there?
Refusals.
Exactly. So refusals, RMAs, sign-offs, whatever you want to call them, they're not listed up there. Because under Medicare definitions, those aren't payable. Medicare does not pay if we don't take somebody to the hospital. There's been some exemptions to that with COVID, but as a general rule, Medicare and Medicaid will not pay an EMS provider if we don't take the patient to the hospital. All right, we kind of hit the definition between emergent and non-emergent already. If you guys have urgent care centers in your district, do you respond the same way? You know, when I worked down at Bangs in Ithaca for a little while, we had a couple urgent care centers down there. They would give us a call. It's kind of like a heads up. Hey, in about 45 minutes, Mrs. Smith's going to be ready to go over to the ER. We're running labs, doing some films, and getting a line in her. But can you guys be here in 45 minutes? That's not an emergent response, right? You're not taking the steps necessary to immediately respond. It's scheduled. So the easy rule is if it's a scheduled response, it's not, you can't make it as an emergency. You know, standbys are questions I get asked a lot about with that. A fire or emergency, you know, law enforcement standby or something like that. Hazmat standby, absolutely. All right, and you can't actually bill a patient for a standby. You can bill a requester. That's totally an agency thing. That's not anything I get involved in. You can have non-emergent standbys too. If the sheriff's office calls and says, you know, hey, we're going to do a raid at 3 o'clock, and you have a crew together. Absolutely, it's 10:14 in the morning now. That's nowhere near an emergent response. All right, so just kind of the differences there. All right, so we talked about those EMD codes, right? And this is where they come into play. You could either use a virtual raise your hand, answer in the chat, or actually raise your hand. How many paramedics or critical care techs do we have in the room here? How many ALS providers we got? So a handful, right? Cool. All right, so how many times do you get dispatched on an ALS level call and take it to the hospital BLS? Quite a bit, right? You know, you get dispatched for the chest pain, and it turns out that it's, you know, some bad advice that Mrs. Jones got from a neighborhood watch meeting. Says that if you want the ambulance, call and say you have chest pain, and she's got a gout flare-up that's been going on for 3 weeks, and that's really why you're there. All right, so you get dispatched on an ALS level call. So let's say a 26 Charlie 1, ALS sick person. So you get dispatched on that, and you take the steps necessary to respond immediately. So you have an emergent ALS response. So you show up. ALS BLS crew it typically is comprised, and it's determined after an ALS assessment's performed, which all you have to do is click the drop down for ALS assessment performed in EMS charts, and that's all you got to do. You got to have an ALS dispatch, so an EMD code. It could either be Alpha Bravo Charlie Delta. It doesn't have to include the numbers. It's however you guys get it. At the end of the day, it's really however Eric wants you to document it. You have that EMD code of an ALS dispatch, an ALS assessment documented, and even if you transport that patient to the hospital BLS, because you were dispatched ALS and because you responded ALS and did an assessment, that trip is now billable at the ALS rate. So dispatch said you had to send a resource, right? It was determined that it was an ALS level response. That's not up to us. Dispatch makes that decision.
Is there any benefit to including the EMD code in the chart or no?
No, as long as it's in one place, Eric. That's typically where our coders. So like if I switch roles from educator and QA guy back to coder, which I occasionally do if I get really bored, doesn't happen often, but occasionally it does. If I switch back to coder and I start to look at a chart for an EMD code, I'm always going to go to that dispatch information first. You can repeat it farther down in the chart, like in the HPI or in the activity log, but you don't necessarily need to. So up in the top on page 1 in EMS charts is definitely where we're going to look for it.
So for the people here, that is why we tell people that on that page 1, we have to put what we are dispatched to, not what we find when we get there.
Absolutely.
Seem to get a lot of resistance from people.
Yep. And I've actually got some blacked out waves charts that we're going to go over here in a little bit, and go over the anatomy of what needs to go where. So you know, I got a lot of pushback from different places. The big one was Saratoga Springs Fire. And they're a pretty interesting department. Everybody in that department, from the chief on down, is a firefighter paramedic. The whole agency. And they have transporting ambulances, and I'm in a room at 9 o'clock in the morning with a bunch of fire guys on shift, and they're like, "Hey, aren't you kind of screwing the patient with that thing? You know, you're charging ALS even though you didn't do anything." And I use the analogy. It was October of 2019 when I was up there, and I use the analogy of an HVAC issue. You know, you turn on your furnace for the first time, it's not acting right, makes a noise you've never heard before. You call the HVAC company shows up, activates your furnace, it makes that noise. You go, that's normal operation. It's okay. Is that HVAC person going to give you a bill, even though they didn't do anything? Absolutely they are. Sure they are. And you're paying for their expertise and their knowledge and their assessment of your HVAC equipment, right? So same thing. The patient or their insurance company, their payer, is getting billed because something determined that we needed to send an advanced life support resource there. We sent it there, and through the knowledge and expertise of that ALS provider, it was determined that those resources weren't needed. Same thing. All right. And I don't have your charges in front of me, but I'm almost certain that there's a pretty significant difference between an ALS level charge and a BLS level charge. So it's two simple things: the ALS assessment being documented and the EMD code, and you're not leaving a lot of money on the table anymore. Whereas if you don't do that, folks do tend to leave quite a bit of cash on the table that they're otherwise entitled to through reimbursement. And we just talked about how that applies, right? It's just got to come from a 911 center using some kind of accepted protocol. And we already talked about how Onondaga County uses EMD. That's obviously accepted. So you're covered all the way around. There's 2 times that are important to document on your chart. First one's on location. All right, that helps to prove that you responded emergently. All right, or that you responded immediately. If you get detoured in your response by an MVC, a train crossing, construction detour, go ahead and document that you had a little bit of a detour and you had to go some way other than your fastest route, because if your agency gets randomly selected by Medicare, and occasionally that happens for an audit, or the chart randomly gets selected for an audit, they're going to look at, using Google Maps or whatever, Yahoo Maps or MapQuest or whatever, how long it should take to go from point A to point B under normal traffic. And they're going to look at the mileage, and they do the same thing for the transport to the hospital. They're going to look at the mileage, shortest distance usually. They'll look at the same thing to see if you're factually documenting that you had an emergent response or not. And 99.9% of the time, you guys don't even know this gets audited because there aren't any issues. The only time anybody's made aware of it is when there are issues found. And if there's an audit and they find an issue, what do you think they do? Do they just look at those issues and go about their day, or do they dig deeper?
I think they dig a little deeper.
Eric's got it. They dig a lot deeper, right? In 2019, for every $1 that CMS spent in fraud and overpayment investigations, they recuperated 9. So they had a 900% profit in fraud and overpayment investigations. Of course, they're going to dig deeper if they find something on a routine audit. All right. The other one is at patient side. All right. And that's when can we agree that that's when your first assessment starts, when you're at the patient side? You may not have laid hands on them yet. You may be doing your doorway assessment, right? Everybody knows what I mean by doorway assessment. The first that you walk around that doorway and it's the first time you set eyes on your patient, it's your doorway assessment, right? From that initial look at that patient, for the most part, we're able to tell if the patient's sick or not sick, right? We're able to kind of tell how that call is going to go, right? So that's an important time to document. That's when your first assessment should be done. Now, I'm not saying that's when your ALS assessment should be done, but we're going to kind of get that hair standing up on the back of our neck or not. That's determining if it's going to be a bad call or not, or if it's going to be a critical call or not. So documentation is held up by a foundation, and there's 4 pillars that hold that up. The first one, unfortunately, is transportation. We talked about how Medicare and Medicaid don't reimburse, and we don't take the patient to the hospital, and that's still true. Federally, we still fall under the Department of Transportation and the National Highway Traffic Safety Administration. All right. If you look at the back of your EMT or paramedic book, somewhere in there, it says that it meets the guidelines of the EMS educational standards set forth by NHTSA and the DOT. We still fall federally under transportation, not Health and Human Services, where most of us think we probably should be. We're still under DOT. Interventions. It's important that we document each intervention that we make on our patients clearly. We'll talk about why in a few minutes. HPI, we're going to dive real deep into what an HPI is. All right, why'd the patient call EMS? Are you documenting your OPQ or STI on each call? And then chief complaint. That often dictates the level of service, right? The chief complaint to the caller. But the chief complaint, when you get there and say, hi, my name's Jason with the ambulance, what's going on today? A lot of times that's different. All right, so that gets documented in the chief complaint, not in your dispatch information. All right, so what's the important stuff here? First off, the chief complaint. Why did the patient call for EMS for treatment and transport? Sometimes the information we get on dispatch and the chief complaint we get from the patient when we get there are one and the same. Sometimes they're not. All right. Sometimes they're not. All right. Chief complaint, sometimes we want to write down none. Now take your EMS provider hat off for a minute and put on a new hat that I got you guys. Person who signs checks at the insurance company. That's what your new hat says. And if you have a claim come across your desk and the chief complaint is none, are you going to write a check for it? No.
Nope.
Nope. If that chief
Try telling some people that.
If that chief complaint says for transport with no other information, are you going to sign the check for that? Probably not, right? So sometimes we're like,
the insurance company, their first motive is always to deny the claim. So if you give them any reason to justify that, they're going to take advantage of that.
Absolutely, right? Eric just hit the nail on the head. The job of an insurance company or any payer is to take the money from the people that subscribe to it and not give it back out. That's how they make money, right? Think about your auto insurance company. It's mandated that you have auto insurance, right, to drive your car, and hopefully you never have to use it. But what does that auto insurance company have no problem doing every single month? Sending you a bill and taking your money, right? Same with healthcare. We're going to get into how auto insurance and EMS go have a relationship here in a little bit. So you can't have a chief complaint and none. And I know sometime, maybe, many moons ago in EMT school, somebody told you that your chief complaint is what the patient tells you in quotations, and that's it. That's partially true. Hi, my name is Jason with the ambulance. What's going on today? My chest hurts and I'm having a hard time breathing. Chief complaint in quotations, my chest hurts and I'm having a hard time breathing. Perfect. Well, what if your patient's unresponsive? They can't tell you that. So what's their chief complaint? Unresponsive. If there's a bystander there who called you and tells you what's going on, you could document per bystander, quotes, they passed out 5 minutes ago. Something like that. But none doesn't work. If the patient's in cardiac arrest, you know what their chief complaint is? Cardiac arrest, right? If you're getting somebody from an urgent care center, transfer for a cast application or transfer for blood work, that's not really the best chief complaint in the world, even though that might be what we're doing. But why are they getting that? Patient being transferred from urgent care for arm fracture, not able to be, handled at urgent care or something similar to that. I'm going to segue a little bit ahead right now, but it's a good time to talk about it. Is medical necessity. And you're probably saying, wait a minute, we don't do interfacility transports here. Medical necessity isn't a big deal. 100% incorrect. Medical necessity is being scrutinized now, even on 911 responses. One of the things that Medicare was starting before COVID-19 started was the ET3 project, the Emergency Treatment, Triage, and Transport project, by either, treating in place, and Medicare is actually paying for it, also known as an RMA or a refusal. Alternative destinations or telemedicine, things like that. Currently, they don't pay for that kind of stuff. Sometimes it's not medically necessary for the patient to go by ambulance to the hospital, right? Some of these patients we can treat at home. We can take to an urgent care center. So they're starting to look at medical necessity. They're not really denying any payment yet, unless it's grossly not medically necessary. but it's starting to be looked at. One of the commercial services to the northwest of you guys, we're doing a pilot project with them for medical necessity auditing on 911 calls, and some of the results are kind of interesting with it. But remember, you know, when you do this documentation, you have to show, you know, why the patient's going to the hospital, right? So keep that insurance company hat on for a second. The person who's determining if this claim is going to get paid wasn't there. Wasn't there. They're not your partner. They're not somebody that you came back to the station and told about the call later. They weren't there. I know there's some disparity in thought processes as well about people at the hospital. Do they read our charts? Do our charts matter at the hospital? They may not matter in the ER because our chart might not get locked and spit out in the fax machine, either directly to the ER. Maybe it goes to med records or whatever. And that's not really important in the ER because we have that time to do that face-to-face handoff with either that nurse or that provider for that patient in the ER, right? That patient gets admitted to the ICU or to a medical floor. We haven't had that hand-to-hand or that face-to-face handoff. That's who's going to read our patient care report at the hospital. And remember, they weren't there either. So when we write this, we have to be pretty specific on what we did, what we found. I'm sure you guys have all met a physician, and I know Dr. Fulligar. He's actually a friend of mine. We've worked on lots of projects with the Collaborative Protocol group and some other things at the state level before, and he'll tell you that EMS is the first eyes on people, and the folks in the hospital don't necessarily get to see what we see. So having that documented appropriately and clearly somewhere is important. All right, it's not only important for billing and all that. It's important for the clinical care of that patient as well. All right, so the HPI, the history of present illness or the history of present injury. That's where you document what's going on with your patient, not what you found on your assessment or the interventions that you performed. The HPI is purely what you found with your patient, what they told you, what their story is. All right, we love mnemonics in EMS, and one of them is OPQRST for medical patients. I added I to it, not only for this talk, but for when I teach EMT classes and the like. I added I. So we know what OPQRST is: onset, provocation, quality, radiation, severity, time. I added I for interventions. Can a patient provide their own interventions before we arrive? Either directed by 911 or something they've been directed to do themselves by their doctor? Sure, they can. They might take aspirin as instructed by 911. Maybe they've taken their own nitro, used their own inhaler, something like that. Maybe our colleagues in fire or law enforcement who gets there before we do have provided some interventions as well. Those need to be documented in the HPI as well. All right, pertinent negatives are equally as important as all the OPQRSTI stuff, all the sample stuff, all the pertinent positives. The pertinent negatives are important as well. Who's been on the witness stand before with a chart? Pleasant experience? No, right? You know, so Mr. Haig, what do you mean you brought your patient into the hospital and they didn't have any chest pain when you dropped them off, and 20 minutes later they died of a heart attack alone in an ER room because they weren't triaged appropriately? Nowhere in your chart does it say that Mrs. Jones wasn't complaining of chest pain. Well, you know, sir, what happened is I was just lazy with my pertinent negatives that day. She actually didn't have chest pain, but I forgot to document it, so it's not my fault. Does that work? No, that doesn't work at all, right? This old adage of if it's not written down, it didn't happen, that's true. That's absolutely true. Back to being on the stand for a minute. Eric and Daryl probably know this because they've been on the stand, but when your patient care report is entered into evidence, it is considered a truthful, factual, legal document regardless of the testimony by anybody else. Regardless of your testimony, even as the author. All right.
One of the things, Jason, that I've heard throughout my career is the most common charting error is omission.
Yes, omission or incorrect repeated information. Like it's listed in the HPI and then it's listed again down in the activity log or something, but the two things that are supposed to be the same are different. Omission, absolutely, as Eric mentions, is a big issue. And the other issue is inconsistent information. But your chart, regardless of your testimony, is considered factual information. How many people have had a chart entered into evidence before? I guarantee everybody in this room has. I guarantee everybody in this room has had their chart subpoenaed and you don't even know it. You don't have to. Your chart gets subpoenaed, and for the most part, that's enough. That's enough. The last time I was on the stand for an hour and a half in an attempted murder case. I was called as a witness for the prosecution. I was on the stand for half an hour for them, and I was on the stand being cross-examined by the defense for an hour. They will use your documentation to poke holes in your credibility, to poke holes in your education, your background, anything they can. I show it in my EMT class all the time. I have the 75-page of double-spaced court transcript of my last time on the stand, and I provide it to people as a little bit of educational tool for what it's like to be on the stand and what the cross is like. And the more that your chart could back up what you did, the better. They tried to use my chart as and my testimony as grounds for a mistrial because I documented that I heard the person say who shot them. They tried to say it was hearsay, even though we said it in the back of the ambulance. But anyway, all that stuff's important, right? Not only for clinical stuff, not only for billing, but the medical legal side of things as well. I know, one of the main reasons that Eric and I put this together this morning was to make sure you guys are getting, reimbursed as much as you can. But I want to keep you guys out of the witness stand as well. And I want to make sure that you have a good documentation for the continuum of care for your patients also. So I want to hit all three prongs here, right? And that's why we just kind of went off on that tangent for a minute. If you're doing any kind of transports at all, make sure, and even on your 911 jobs, make sure there's some kind of documentation for why that patient needs to go by ambulance. And I know sometimes it's really hard to do, and sometimes there's not a reason, and that's okay. Don't fabricate one. Sometimes we're mandated responders, right? Sometimes we just have to go pick them up and take them to the ED, whether it's necessary or not. But if you can document the reason why that patient called an ambulance and why they need to use us, that's the best option. All right, so interventions. I know I touched on that a few slides ago, and here's the meat and potatoes of it. And I totally forgot and omitted changing the logo on this slide, and I apologize for that. There should be a Waves logo where that Greater Baldwinsville logo is, and I feel like a knucklehead. But so what'd you do for?
You recognized it.
I absolutely, even though I went through this 3 times last night. So what'd you do for your patient on the call? What did you do? Is moving your patient an intervention? Yeah, absolutely. How about patient positioning? Sure. Is every IV attempt a separate intervention? Yes. Yes. Even though EMS charts allows you to say, successful, unsuccessful, how many attempts? Don't do that. That doesn't work out real well when you try to query a report for that. Like Eric might try to pull IV stats for the agency every quarter or something like that. And if you use that attempts box and you don't have, an attempt for activity log line for each attempt, that report's going to have skewed data in it. More importantly, if we're giving medications to somebody or performing other interventions, it needs to have its own activity log. All right. Are you really starting 3 IVs in a 60-second time frame? Go back to that thing on the witness stand. It's a factual document, right? It's considered to be a factual document if your chart's entered into evidence. So at that point, you're saying that you did 3 IV attempts in a 60-second period. Is that true? The answer is probably not, right? Are you doing a 4-lead and a 12-lead at the same exact time? Are you initiating cardiac monitoring and doing a 12-lead at the same time? Maybe. Maybe not. You should document appropriately with timestamps what happened when it did. And the cool part about that is our monitors tell us when the initial rhythm was, when we hit that 12 lead button, right? That's pretty easy. The data that we could get off the monitor is pretty easy. I drive my paramedic students nuts when they're with me on the fly car. Everything I do, I hit the event button on the monitor. It's timestamped that way. That's just what I do. Drive some people crazy, but I don't have to guesstimate times at that point. Are you truly giving morphine and Zofran at the same time? That's a great example. Maybe you are. You're probably not, right? If you're giving it at 2 different times, document it on 2 different lines. This can make a huge difference in what level of care your call could be billed at. And that brings us to ALS2. So does anybody know the textbook actual definition of what an ALS2 call is right off the top of their head? No. We're going to go over it. All right, so some people might have learned that ALS2 is you give 3 or more medications. That's partially true. But those 3 or more medications have to be given by IV or IO only. And it includes any kind of crystalloid fluids. So if you give somebody 3 saline flushes, that does not count. If you do 2 boluses of D10 on a diabetic, that doesn't count. You're doing a saline infusion and give 2 doses of morphine. That doesn't count. All right. And as I mentioned, it has to be IV or IO. None of the other routes of administration matter for ALS2. Why? Can EMTs give medications PO? Absolutely. Can they assist patients taking their own medications sublingually? Yeah. Can EMTs do IM injections? Yep. Intranasal? Yep. Nebulized? Yep. So what's left? IV or IO is the only true ALS mode of medication administration. Now, I want to draw your attention to the fact that we're only talking about the mode of administration, not the medication. All right. And also, this is a national guide. This is not something that's New York State specific or CNY region specific. Granted, most of us in New York State, except for the island and cities of more than 1 million, are all on the same protocol. But it's only the route that matters, not the med. All right. So an example would be 50 micrograms of fentanyl, 4 milligrams of Zofran, 50 micrograms of fentanyl, IV. Is that an ALS2 charge? Absolutely. Absolutely. 324 aspirin, 0.4 nitro, 4 milligrams of Zofran, 2 milligrams of morphine IV, 2 milligrams of morphine IV. That's ALS2. What if we only gave 1 dose of morphine on that call? No, because the aspirin and nitro don't count towards it, right? Or we get these crazy respiratory patients lately, right? Where maybe we're not nebulizing them because of the COVID stuff. So maybe we're giving them epi and decadron and mag. That's cool. 2 of those are IV, right? How are we giving the epi? IM. So that doesn't count either. All right. So those are the meds. There's procedures that can also get you ALS2. Right. The first one is any kind of manual Edison medicine, any kind of manual electricity. So manual defibrillation. You can't have your monitor in AED mode and defibrillate a patient, even if you're a paramedic, and have it count. It has to be manual. It has to be manually defibrillated. Basically, that means the provider has to look at the rhythm, determine that it's shockable, select an energy setting, charge it, and deliver the shock. Now, that doesn't have to work. The defibrillation attempt doesn't have to work. It just has to be attempted for it to count. Same with cardioversion. Obviously, cardioversion is manual. Cardioversion doesn't have to work. It just has to be attempted. And the other form of electrical therapy here is cardiac pacing. We have to attempt cardiac pacing. It doesn't have to get mechanical electrical capture. It simply has to be attempted to get ALS2. Endotracheal intubation is the same way. It doesn't have to be successful. What's considered an endotracheal tube attempt?
The blade passing the lips.
There you go. Absolutely. That laryngoscope blade goes inside that patient's oral pharynx, and we have an endotracheal tube attempt. Now, sometimes we put that blade in and we can't see a damn thing, right? So we go to a supraglottic. If you don't document that look and you just document the supraglottic airway, you just lost ALS2 as far as the airway goes. Because the supraglottic airways don't count. In some states in the country, EMTs are placing supraglottic airways. So supraglottic airways do not count towards ALS2. So if you take a look and decide, oh my God, this is a Mallampati bad, and you pull out and you go with the supraglottic airway, which is fine, you're not going to get ALS2 if you don't document that endotracheal tube attempt, which, as Daryl mentioned, is that laryngoscope blade going past the lips. Central venous lines, we don't do those here. Talked about pacing. Chest decompression. Anytime we pop a chest, that's automatically ALS2. All right, so your traumatic arrests, your tension pneumothoraces, anytime you're popping a chest, it's ALS2. Surgical airways, ALS2. I've made it 16 years without doing one. I want to make it another 16 without doing one. But that'll automatically get you ALS2. And the last thing that qualifies for ALS2 is IO access. Anybody want to take a guess of why IO access got added to ALS2? Because the procedure's pretty easy.
The price of the equipment to start one?
Absolutely. The IO needle's what, $150 a pop still?
Yep.
Somewhere around there? Yeah.
Yep.
Yep, they were when I used to order supplies all the time. So
technically, if you get the IO, if you attempt the IO, then that's automatically ALS2 without giving a med that route?
absolutely. Yep.
Okay.
Yep. So it doesn't have to be the procedures and the meds, it's or. So it could be the meds or the procedures. If you run a cardiac arrest, obviously you're doing a lot of things on this list. And actually I have a cardiac arrest chart from you guys that we're going to look at in a little bit. So ICD-10 codes, I realize, one, that there's a lot of stuff on here, and two, I broke every PowerPoint slide rule in the book with this slide. Way too much stuff on here, and I did it on purpose. And I also realize you guys don't worry about ICD-10 codes, which is true to a point. Take a look at some of these. I'll draw your attention to I-26.99 over here. Other pulmonary embolism without acute core pulmonale. What the heck is that? It's pretty specific, isn't it? Some of these other ones are not. Some of them are. ST elevation MI, unspecified site. Unspecified AFib. Heart failure, unspecified. Some of them are more specified. Your non-emergency. ICD-10s are a little bit more specific. But nonetheless, these are pretty specific, and our coding staff has to assign 1 to 3 codes to each one of your claims, and that's what the insurance company actually looks at initially when they're determining if they're going to pay the claim or not. So I think it goes without saying, and the reason that I put all these up here is that the more specific you are in your chart, the easier it is for my coding staff to assign an ICD-10 code or codes to it. And once they do that, you guys have a much higher chance of getting paid what you're due. I'm not saying that we get reimbursed nearly enough. We don't. But having every opportunity to get as much as we can is really what we're trying to do here. So I know you guys don't do a lot of non-emergencies, but this is just an example of the specificity of ICD-10 codes for non-emergencies. Let's go with I-69.944. Monoplegia of the lower limb following unspecified cerebrovascular disease affecting the left non-dominant side. Anybody that's ever worked commercially MS that did nursing home take-homes before? Were you ever that specific in your chart that it affected their non-dominant side? No. We learned.
Are you talking about these ICD-10 codes for the medical history part of the chart?
No, nope. This is what's actually going on with the patient. We don't necessarily have to put it on for the medical history, even though EMS charts does that. I don't know why. It's a NEMSIS thing. But as far as what's billable is what's going on with the patient at the time of that encounter.
So we really don't have a place to do this.
No, you guys don't assign ICD-10 codes.
Got it.
ICD-10 codes are assigned based off of the information in your documentation. So the more specific that you could be in your HPI, in your activity log, the easier it is to give accurate ICD-10 codes to these strips. So you guys didn't go to coding school. You don't want to go to coding school. Trust me. If you've ever been to EMD school, they're kind of one and the same. If you haven't been to EMD school, don't do that either. But our coders take the information that's in the chart and assign specific ICD-10 codes to it. And the more specific you are in your chart, the more ICD-10 codes we can assign that are specific. And the more ICD-10 codes, right, the more proof, the better case you have. Same thing. The more ICD-10 codes we have, the better case you guys have of getting paid. So we're transporting to the hospital. Are we transporting to the right facility? If you look at the front of the New York State BLS protocols or the front of the collaborative protocols, it says that the patient needs to be transported to the closest, most appropriate facility, right? You know what Chapter 10 of the Medicare Guide on Reimbursement says? That EMS needs to transport the patient to the closest, most appropriate facility. It's not a mistake that the protocols have that same language in them. It's not a mistake at all. All right, what's an appropriate destination for your patient?
That has to do with mileage, right, Jason? They'll only pay the mileage equivalent to the closest appropriate facility,
Absolutely.
even if you go to a farther facility.
Sure. And you know, in the Metro Syracuse area, that's not really a big deal, right? You know, community versus upstate downtown versus St. Joe's. Those are all pretty much in a 10-mile radius, right? So it's not really a big deal there. It's like if you pick them up in, you know, on University Hill and they want to go to Oswego and they don't have a reason to go to Oswego. I don't know why anybody would. That's not going to get paid. There's no reason for that patient to go to a farther facility. Out where I am, I live right between Rochester and Syracuse and Geneva. If somebody wants to go to upstate from here because that's where their doctor is, that doesn't work. You can't transport to a facility because of a preferred provider. The hospital has to only be capable, equipped, and staffed to handle the patient's condition, not a preferred provider. So the closest, most appropriate facility has to be appropriately staffed and appropriately equipped. That's it. If it's a specialty need, STEMI, stroke, trauma, mental health, you go to the appropriate facility for that, even if it's a little farther away. And Eric hit the nail on the head. That's because of mileage. When we were seeing the surges with COVID patients, a hospital that does not have any inpatient beds available is not an appropriate facility. Years ago in Rochester, they used to put color codes on their hospitals. Red, yellow, or green. Green, they're open. Yellow, it's going to be delayed. Red, they're on diversion. Don't come here. We're full. That's not necessarily a legal thing in New York. Diversion isn't. But it's technically not an appropriate facility if there's no inpatient beds for that patient in that hospital. So you can actually bypass, if you know ahead of time that your patient is, you know, admittable. They're not a treat and street kind of patient. They're admittable. And you know that there's no beds in that hospital. You could bypass to one where there is. That's okay. The key is you need to know that information ahead of time, and often we don't. All right, so mileage, that needs to be documented the nearest tenth of a mile up to 100 miles. After 100, it's the nearest mile. All right, but hopefully we're not taking very many 100-mile or longer trips, so anything under 100 miles gets documented the nearest tenth. All right, so enough of me yakking here. We're gonna laugh at some other people's misfortunes here for a second again.
So a couple more Medicare definitions that apply here. All right. Appropriate facility, we kind of hit that already. Hit all that stuff too. Hit all that. So billing signatures. Billing signatures. Those darn signatures we've got to get at the end of every call. All right. That form's technically known as an AOB, or an assignment of benefits form. And the sections are listed in order of preference. Right. We prefer section 1 to get signed first. Section 2 to get signed if nobody can sign section 1. And section 3 is the last resort. So for somebody to sign for themselves in section 1, they have to be competent. They have to be competent. They have to be over the age of 18. If the patient's had a couple beers, they can still be competent, right? If there's any witnesses and you have any kind of doubt, have a witness sign that the patient signed section 1. If the patient's under 18, the parent or guardian may sign section 1 for the patient. All right, patient under 18 can sign for themselves with a couple of exceptions. If they're emancipated, there's nobody today that is young enough to be emancipated who could have possibly gotten emancipation orders, because New York State has not issued them in over 20 years. So if a patient tells you that they're emancipated, that's not true. If they're enlisted in the United States Armed Forces, they could sign for themselves. Or if they have a child, they could sign for themselves. All right. Legal guardians and parents of a patient who may not necessarily, a patient who's over 18 who may not necessarily have the capability of making their own decisions, could sign section 2. So a patient with MR or some other kind of developmental or physical disability, the parent or legal guardian can sign for them in section 2. Relatives or friends who handle the patient's affairs can sign section 2 if the patient, for whatever reason, is not capable of signing section 1. The overarching rule, though, is that if the patient's not dead, they should be signing section 1. Now, there's other circumstances: patient's death, injury to their dominant hand, patient can't see and their glasses are broken, altered mental status, things like that. Or a representative of an institution that provided care or support can sign for the patient in section 2. That's the last choice in section 2, realistically. You pick up a patient from a nursing home, from a memory care unit, and a patient's obviously not capable of signing for themselves. You can have the staff at the sending facility sign for that patient. So how do you do that? I keep a couple, typically my personal practice is I keep a couple of those AOB forms in the back flap of my monitor. I usually don't go anywhere without my monitor, and I have some signature sheets right in there. Or if I, go into somebody's house and I end up getting a refusal, there's a couple of refusal forms in there as well. Just so I don't have to go back out to the car and get them. So that's section 2. Last resort, patient can't sign for themselves. There's nobody else present who can. You go to section 3. That's where the medic signs for the patient and a hospital representative signs for the patient. But that's only when 3 circumstances are met. 1, patient's unable to sign. 2, there's nobody else who can. And the circumstances are fully documented. Patient is in exam with hospital staff. That doesn't work. That's code for I was too lazy to get a signature, and when I remembered to get it, I went back in and they were busy examining the patient, and I didn't want to interrupt them. I used to do that all the time.
I have a slight argument with that.
Yes, sir.
What do you do in a situation where they rush them to surgery after 2 minutes?
Then they're in surgery. They're not being examined anymore.
Okay,
If they're still in that exam room, you don't want to interrupt the 12 lead that they're doing or something like that. That doesn't work. But if they've rushed them to CT or to surgery, that's a totally different story.
Okay.
Patients been rushed for emergency surgery. Patient taken for emergency diagnostic imaging or something like that. That's fine. That's fine. And the hospital signature doesn't necessarily have to be anybody involved in the care of that patient. It doesn't have to be a nurse. It doesn't have to be a doctor. It could be anybody who was employed by that hospital who's willing to sign that you brought that patient there. So it could be the unit clerk. It could be the patient care tech. It can be the housekeeper, but I've never met a housekeeper that'll sign a patient form ever. But those are your 3 reasons to get section 3 signed. And if for some unknown reason you're not able to get a signature for whatever reason. Say you take them to a smaller hospital, and it's Armageddon in there. A hospital face sheet is proof that you took that patient to that hospital. Now, I'm not telling you guys under any circumstances not to get both signatures on Section 3, your signature and the hospital signature. But if for some crazy reason the hospital, blows up and there's nobody there to sign for you, there's a bus that just overturned on 690 and the hospitals are overwhelmed. Okay. But having both of those signatures in Section 3 should be the gold standard. Underneath the gold standard of having Section 1 signed, if at all possible.
So that's pretty much proof that you should get a face sheet for every patient.
Absolutely. We're going to go into even more reason why you should get face sheets in a minute.
Jason, let me ask you a quick question about signatures. We had a question pop up the other day. The patient did in fact sign on their own behalf, but they didn't date the signature. It was caught later when we reviewed the chart that there was no date on the signature. So the provider was reluctant to put that on there because she felt like there was a legality of that she couldn't put the date in at a later time.
So there's been some stuff going around the EMS community about that. One of our counterparts in the world of EMS billing says that the patient has to date their own signature and nobody else can. That's not necessarily true. You can, how do I put this? As long as the date of the signature matches the date of service, you're okay.
And we certainly are not doing it maliciously. You're just kind of crossing the T's and dotting the I's at that point.
Absolutely. Absolutely. For sure. For
that reason, I fill out the date for 99% of my patients for them. So it's less that they have to do.
Absolutely. There's nothing worse than trying to get, little Mrs. Smith who just fell and broke her hip. She's 98 years old to figure out what the date is, let alone write it down. You're already having a hard enough time doing your signature. Put the date down. It's not a big deal.
I have one more question. Hold on one second.
Yes, sir.
Because I have Ryan with me.
Okay.
Jason, have you seen our signature pages for both Manoa and Wave?
I have.
On there, so at the top we have the insurance information that we handwrite in there.
Yes.
Is that beneficial? Is that something worth taking out?
It's beneficial. Ultimately, the PCR is the chief document that we get our information from. So if you enter that same information in EMS charts where that insurance information is, that's awesome. That'd be ideal. But
so
having that,
beneficial for us to have that.
It is beneficial for you to have that because that's a great place to collect it and then put it in EMS charts later.
Okay, thank you.
Absolutely. My personal opinion on it is I wish more agencies did do that. Because that's a thing that says, oh, I wrote down the patient's name on here. Yeah, I should probably get insurance information from somewhere. So it almost forces the provider to collect that information, which is a good thing. So I would say keep doing it.
Jason, I got one more question for you.
Sure.
When it comes to the competent billing signatures, like you said, you just said that you just saw the signature forms that we have. Where exactly on that form would you want a witness signature?
Your guys doesn't have the witness signature on Section 1, does it? You could just have them sign next to Section 1 and write witness underneath it. That'd be okay.
Okay.
That'd be okay. I'll send Eric a couple of editable signature forms that he could take a look at too. Some links to them from Page Wolfberg and Worth. They've got a couple signature forms that you can actually edit on there. So if it's something you want to take a look at, there is a provision for billing signatures right now with COVID that we can sign Section 1 on behalf of the patient if they're suspected to have suspected or presumed to have COVID-19. We can actually sign Section 1 on behalf of the patient on one of these forms. So Eric, I'll send those over to you afterwards, so you've got them to take a look at.
Okay, another question here, Jason. Our forms is kind of opposite of yours. 2 and 3 are opposite.
Okay.
Does that make a difference?
No.
Okay, I just didn't know if we had to change that.
Um,
I would rather not, but if we needed to, we could.
Yeah. It should go 1, 2, and 3.
Our
And-
number two is the hospital representative and the crew.
Yeah.
And our number three is the family or patient representative.
Yep. So your number 2 should be last resort, and then number 3 should be your second.
Okay, no, I understand that. I
Yep.
just didn't know if it was, if it was real, if we really should change it or not.
I'll let you guys make that decision based off what I send over to Eric as a resource later. So,
Okay.
As long as
So
you-
also said for COVID patients, we can sign on section 1
if you have the proper form,
if we have the proper
because
form. Okay.
it basically what it
Well-
has in there, Daryl, is a clause that says that you're doing that for the patient.
Yep. So what we've been doing, and you
Mm-hmm.
can tell us right or wrong or indifferent, is we've been doing our section 2 where we sign and the hospital signs, and we've been putting reason patient can't sign is biohazard.
That's absolutely fine. That's 100% okay.
So that's what we've been doing.
Because this whole patient provider signing for the patient thing
Yep.
was put out there, but it was not really publicized to the masses, so to speak.
Yeah, we
So-
put out there biohazard due to possible COVID.
Yeah, absolutely. The agency I work at, we don't have the section 1 provision up there. So all my possible COVIDs, I've done the same thing, and it's
Okay, so
absolutely
we're-
fine.
Perfect continuing doing it that way.
Sure. Yep.
Okay, thank you.
Absolutely. Sure. So phone numbers. Why are phone numbers important? And sometimes those are like one of the last demographics that we remember to get. But why are they important? We're all human, right? We've all transposed numbers before. Say somebody's insurance policy is 1, 2, 3, 4, 5, 6, 7, and we wrote down 1, 2, 3, 7, 8, 9 instead. Right? We've all done that, or we've reversed a number in a letter here or there. And for whatever reason, we're looking up this patient's insurance, we're looking up their payer, and we've got the right name, the right date of birth, the right address, and heck, maybe we even have the right social security number. But man, these numbers just don't match. Our staff can make a quick phone call to the patient, verify they are who they say they are, right, with some demographic questions, and confirm their insurance policy numbers. Isn't that a lot faster than sending them something in the mail by the Pony Express, having them open it, having them list their insurance information, remembering to send it back by the Pony Express, and then the Pony Express delivering it to us? That takes a lot of
Jason,
time.
I think it's important to note that the more complete our job is, the more information that we've obtained, the face sheet, the phone numbers, things that make MultiMed's job easier, the lower our rate is.
Yeah,
The more work you have to do on your end, the more you have to charge as a commission. Is that correct?
No. Commissions across the board. That doesn't matter. What matters is how. No. But what matters is
Okay.
how fast you get paid. Medicare pays every 14 days, as an example. They pay on the 1st and the 15th. So the sooner we could get the claims, and the sooner you're going to have money in your bank account, is really why that's important. And the less chasing we have to do. So the less chasing we have to do, the faster you guys get money. Usually, if we get a full claim in from you guys, a full chart that's complete with everything that we need, it's out of the door getting billed in less than 3 days from the time it hits us. So the time you guys advance it to billing to the time it's going to the payer is less than 72 hours. So the more complete it is, the faster that time is. Social Security numbers is another big one that a lot of patients are often hesitant to give us. They'll give us all the other information that we need to steal their identity, but not their Social Security number. I often am successful with this by just simply reminding the patient that everything that I've collected from them is confidential under laws like HIPAA, that this can't be shared, that this is for our information only, and the information for the hospital, and that's it. And then they will 90% of the time provide the Social Security number. Why is that important? It's important to us for a couple of reasons. If we're verifying payers, oftentimes we'll verify by the subscriber's Social Security number. Up until recently, if you had Part A Medicare, it was their Social Security number with an A at the end of it. Now they have unique Medicare ID numbers, but prior to that, it was their social with an A at the end. We also subscribe to a payer clearinghouse where, if for whatever reason, the patient doesn't have a listed payer, which means they're self-pay. We don't get a lot of returns on self-pays. On the patients that are otherwise self-pay, we subscribe to an insurance clearinghouse, and if we have as much demographic information as possible, about 34% of the time we'll find a payer for these patients that are listed as self-pay. So correct name, date of birth, address, social security numbers. These are all things that we can utilize to search this database to find payers. It costs us a little bit every time we run this, but the return is worth the investment. Not only for us, but for you guys. Obviously, you guys don't pay for it; we pay for it for you. But the return is good. It's about 34% of the time you're going to get a payer on somebody who otherwise is self-pay. So insurance information. Getting the insurance carrier is huge. We can search the patient by that insurance carrier. If we have the number, we don't have to search. We can simply verify. What's even better is a copy of the card. If the ER staff lets you borrow their copier, that's awesome. You get a copy of the card. That's outstanding.
Hey, Jason,
Sir,
devil's advocate here, because this is the pushback that I get. I wrote the number on the chart. Why do I need to make a copy of the card?
did you write the number down correctly?
I don't exactly. That's what. But that's some of the pushbacks we get.
Yep. I'm not necessarily saying you need a copy of the card, but if you have it, it's even better. And then the hospital demographic sheet, the face sheet. The one problem that we sometimes run into there, excuse me, is that the patient's information may have changed since their last visit. Their payers may have changed, and maybe they printed that face sheet off of the information from the last visit. So if you can confirm that information, and that's awesome. If not, at the end of the day, this should not be a stopgap, but at the end of the day, that hospital demographic sheet has that patient's medical records number on it, right? And if we need to verify payer information, we can call over to the hospital with that medical records number and then verify their payers. We have lots of methods of chasing payers for your patients. It just takes time. And the less time we have to take, as I mentioned, the faster we can get you guys paid. But we do have other methods. So addresses. This is a big thing with college students. They don't like to give you their home address. And by home address, I mean where they live, not where they stay at school, where they live. Well, I don't want my parents to find out that I went to the hospital. I understand that you're over the age of 18. You don't have to tell them, but you're still under their insurance. So they're going to find out that you went to the hospital anyway, right? They're going to find out that you got admitted to community at 3 a.m. and you spent the entire day in the drunk tank. They're going to know that. All right. So home addresses, where they get their mail for college students, is important. Temp employees, maybe we get some, you guys get some locums doctors into the area for the university or whatever. They need their legal address, or traveling nurses that are somewhere on contract. Their home address, where they actually get their mail. Hasn't been so much with COVID, but traveling and visiting folks, again, their home address, not the address of the B&B that they're staying at for 3 days. And just make sure that that address is documented. Now, if the patient's homeless, we can't document an address. I understand that. That is what it is. But if we have any kind of address available, please document that in your chart. And as I mentioned, the chief document that we pull information from is the PCR. The rest of the supplemental information is wonderful, but the chief document is in fact the PCR. So,
Quick question for you,
yes,
Jason.
yes.
Plenty of people who live around here who are homeless live at one of the 2 shelters in the city,
Okay.
whether the Rescue Mission or the Catholic Charities. So if they say that they live at the Rescue Mission, is that something that we can use as an address, or is that something, because it's technically a temporary residency, is that something that you would rather not see?
I'd use it. It's their last known location.
Okay.
So I'd use it. So, best case scenario, one of these folks, maybe gets placed, right? They get some assistance, and either the Rescue Mission or Catholic Charities most likely is going to know where they went.
Right.
So that's at least a starting point. It's a better starting point than homeless would be. So I'd use it. That's a great question. It's actually one I've never been asked. So
Jason, a lot of the homeless shelters will have intake documentation that may have next of kin or other information that's pertinent to, so it's a resource to go back on.
Absolutely, for sure. Yep. Yep, absolutely. I've actually never been asked that question. That's a great question. All right, so, yes, sir.
As far as assisted living rehab facilities, is there a limit on how long they're there where that would be considered their home address, or if they're there for rehab and short term, automatically use their home address?
If they're there for rehab short term, 30, 60, 90-day rehab, I'd use their home address.
Okay.
If they're a resident there, that's their address. And that's a whole different ball of wax on the coding side and determining what payer we go after.
Right, and it's in Manoa, that's where we have two facilities. Half of them are half of the building is rehab short term and the other half is nursing home.
Yep.
Is that for both of them?
Yeah.
So
Yeah,
how do
so-
you know the difference?
The 200, I mean, I'll always ask the staff and the patient if they're there short term or long term. If not, it's the east wing versus the north and south wing.
So our
And-
providers can do the same thing, ask, are you here?
And
for-
that's where, make sure you.
Are
get
you
their
here
home
for, are
address.
you here for rehab or do you live here?
Correct.
Yeah, and that just gets really complicated even on our end too. With Medicare Part A and Part B, who is responsible for paying for this? If the patient is discharged from the hospital and they are discharged to rehab, is it part of their initial 100-day stay? If it's part of their initial 100-day stay, it gets billed one way. If it's not, it gets billed another way. If that's information you can include in the chart, that's great. If not, it'll ultimately get sorted out with Medicare anyway. But if that's information that you have the ability to include, great. If not, nobody's going to lose any sleep over it either. So good question. So let's just highlight what we've done so far. Call taking, right? We've identified that the call starts there with the call taker. That determines your level of response and your ability to bill for an ALS assessment, even if we take somebody to the hospital BLS. Response: if it's an emergency call, treat it like one. Take the steps necessary to respond immediately for that call for service. Assessments: make sure they're thorough, make sure they're accurate, make sure they actually reflect what you witnessed, and ensure all the supplemental documents for payment are complete and that they're attached to the chart. Things like billing signatures, PCSs, which you guys don't have to worry about, ABNs, which you don't often use, hospital face sheets are huge, or any other information. The faster that we can process this claim, the more likely payment is. And on that note, auto insurance. Auto insurance will pay 100% of whatever they are billed, but you only have 45 days to submit it. So getting as much information about auto insurance with the patient is huge. Now, if you could get their auto insurance carrier and their number, that's great. Minimally, the 3-digit insurance code is helpful, and you could get that right from law enforcement. Hey, what was the insurance code on the red Honda Civic? There you go. Then we know the carrier. We could cross-reference that 3-digit code with the insurance carrier, and then chase them down that way. That's okay. Obviously, the insurance number would be the best, but the quicker we could chase it down in that 45 days, the better off we're going to be. By the way, the no-fault insurance form has to be signed as well. That's another supplemental document that's important. Without that, we can't bill no fault in New York. And then we have to send the form to the patient, wait for them to open it, wait for them to fill it out, and wait for them to send it back. And that can eat up 45 days real quick. So making sure auto claims are as complete as all the other claims is just as important, because auto pays faster, cuts off faster than anybody else. Daryl.
Jason, is it a good idea to get the patient's health insurance information on a car accident as well, or is that redundant?
If they have it readily available, that'd be good. Health insurance is more likely going to kick in when they get into the hospital and it's more deeper stuff. But if you can get it, that's great. I would personally, Eric, I'd rather have redundancy for payers than not enough. So, Daryl, you're up, man.
So that was one of the three that I was going to ask. The second one, does getting the plate number of the vehicle help in any way? Or
Not
can we
really.
Stop that practice.
You could continue to get it, but it's not really allowed. How do I put this? We can't run down the plate and find the insurance.
Okay, well, no, if it's not gonna do anything, then there's no
Yeah.
sense of us documenting it.
Yeah, we can't run the plate down to find the insurance. We can only run down the insurance. So
Okay. And what was the other one? Shit, no, I forgot the other one.
it'll come to you probably, I'm sure. We're not done yet. So
Okay.
all right. So even though this slide says putting it all together, that's putting together the lecture that we just
Oh,
finished.
I do, yep, I do remember.
Yep, go ahead.
So let's say they were in a car accident last night.
Yep.
Now they call us today for neck pain from that car accident. Am I correct in saying that that no fault form should be filled out and signed?
It's not going to hurt.
Okay,
I'm not entirely sure if we're going to bill no fault, but it's not going to hurt if you have that signed. If it ends up, that's what happens.
okay. And another one, motorcycle accidents,
Yes.
because motorcycles don't motorcycles fall under health insurance?
They're a motor vehicle.
So they do fall under that.
Yep. You're
What
required
insurance
to have insurance on them, so it'll fall under that as well.
So you still need the exact same information for a motorcycle accident as you do for a car accident.
Correct, sir. Yep.
They do have insurance. They just don't have personal injury insurance, I believe, for the owner or the driver.
Yeah. So that's the case where you still want to get health care, but if it ends up being a liability claim or no, the whole no fault thing that gets sorted out among the insurance companies later.
Yeah,
But getting that signed up front is probably not a bad idea.
Insurance code on motorcycle.
now we've been told that law enforcement cannot get an insurance code on motorcycles. Is that correct?
If they run the plate, they can get insurance.
If they
I've
run the plate,
never
they can-
experienced that, but if they run the plate, they can get it.
Okay, we'll look into that.
I always carried my insurance card in my wallet when I had a bike. So
Right.
that way I always had it with me.
Mine was always on my bike.
Yep.
So,
Oh. All right. So now we're going to get into some chart review. These are actual waves charts. They're from last month. And the names of the innocent have been blocked. That includes the patients and the providers. All right. So January 2nd, patient was transported to Krause. And you see that I've highlighted the dispatch priority. Delta. That's huge. That tells us what kind of call. ALS right off the bat, right? That's an ALS job. All right. I like the fact that the receiving RN's name is listed here. That's great. That's a good practice to be in. All right. I just have a knot in my shoulder blade. Man, if I went to the hospital for that, I'd go every day. All right. So patient is a 73-year-old female with no past medical history complaining of left shoulder blade pain, described as a knot in her shoulder blade. Patient describes an episode of left-sided chest pain 2 nights prior that woke her up and resolved after 20 minutes. Patient denies any associated dyspnea, diaphoresis, nausea, vomiting, or recent injury illness. Patient states she also had high blood pressure over the last 2 days. Patient evaluated at well now urgent care and given 324 milligrams of aspirin prior to EMS arrival. Patient history, none. Meds, calcium and D3, no allergies. Based off of that HPI, do we have a decent picture of what's going on with this patient and why we're there? Yeah. So we continue. Go down to her neurologic exam. She's alert and oriented, right? We can see that she's got a GCS of 15. All right, along with all the other supporting information here. Motor and sensory are intact. She's got normal pulses. Everything looks good, unremarkable here. Got a very nicely filled out initial physical findings section. All right, impression and diagnosis are documented. All right, so let's go back up here for a second. This is dispatched ALS. This is dispatched Delta, right? So on top of that, we have that an ALS assessment was completed for the suspected illness. Regardless of any further interventions, that's a billable ALS call. Regardless of if we go to the if we do anything ALS on the way to the hospital or not. ALS call right there. Simple as that to get ALS. All right. PP and surgical mask, we did a 12 lead IV automatically it's ALS, right? So PPE and surgical mask and gloves worn by crew prior to patient contact. Patient has a surgical mask on. We did a 12 lead. We got a first set of vitals. We got him on the monitor. We got a peripheral IV in. It was one attempt and it was successful. More vitals, more vitals. Perfect. There's two things that I would add to this activity log. They're not super important, but it's going to help your timeline a little bit. Your at patient side time, and then in the activity log when you gave report to the gave report at the hospital and where the patient was left. So my usual ending activity log entry: arrived at ABC Hospital, report to triage nurse Jen. Patient to hospital bed in room 7 via scoot over, side rails up, ×2, bed lowered. Patient signed AOB, EMS return to service. Something like that's usually how I'll end a chart. Personal preference, it just rounds out the end of the call pretty nicely. One of the things that I learned doing this job and reading a couple hundred charts a day that I started doing, now it's not required or anything, but I think I started using it as a practice off of reading somebody else do it. Your initial, arrived at patient side, introductions made, chief complaint, alerted chief complaint in HPI. That's what I used to write for my first activity log entry. Then I added informed or implied consent obtained. For over a decade, almost 2 decades, I was never documenting anywhere that I got consent to touch this patient. Wasn't documenting that anywhere. And then I saw somebody do it and I'm like, that's really a good idea. Right? Up until that point, I was not documenting that I'd received any kind of consent to touch that patient. So if I didn't write it down in that chart that I had consent and somebody wanted to come back on me 5-10 years later, at the end of the day, I didn't have a leg to stand on. So just a recommendation, nothing that's required by any means for billing or for, protocol compliance or anything like that, but just a recommendation of a good practice that I saw that I adopted. All right. Just one chart, and then we're going to look at some other, we're not going to look at exactly the whole thing on this one. This is an echo level. Odds are it's probably a cardiac arrest. You got a crew of 4, so probably an arrest, right? I know it's an arrest because it says patient death at scene with resuscitation attempted. All right, completed for suspected illness. Per patient's family, they came to check on him and he was not waking up, states he was not breathing, and called 911. For family, this is an unwitnessed arrest and it is unknown how long the patient's been down, stated he was last talked to yesterday. Family states patient has cardiac history and has been struggling with medical issues as of lately. All right. Unwitnessed arrest. IO initiated. What level of service is this billable at automatically?
ALS2.
ALS2, absolutely. So we get some oxygen by BVM. We drop some epi. So that's 1 med by the IO. All right, we put in a king, so we can't get ALS2 off of that. But that's still an important intervention anyway. So we're ALS2 based off of the IO, but let's look at meds here. Let's say that the IO didn't happen. So we got 1 round of epi by the IO, another round of epi, another round of epi, another round of epi. ALS2. Ideally, but we didn't take this patient to the hospital, right? As dead at scene. We attempted resuscitation to the field termination. So we can't bill for ALS2 on this one. This is a DOA charge. That's it. All right. And we could have a discussion on why these charges are messed up and why those rules are messed up for a long time, but not the place for it. This is just a rule. These are the rules that we have to play by. But this is definitely an example of an ALS2 charge, but because the patient wasn't taken to the hospital, which is probably the appropriate thing to do if the patient was asystolic. 3-lead asystole is the appropriate thing to do. Unfortunately, we just can't get billed at the ALS level 2, even though that's what we did. It's a DOA charge, and those are the rules. But this is a well-written chart. Each intervention has a separate entry. Paints a good picture. So well done on this one. And one last bit of humor before we finish up here. And I guarantee you all know people that have done this if you haven't done some of these things yourselves.
All right, you ready? You're holding him tight. Push forward the palms. Lock the elbow right there.
fast. No! Come on!
We don't use backwards for anything else anymore.
Definitely done that before.
Absolutely. All right, so I'll entertain any questions. You guys are pretty interactive throughout, which is awesome. But this is my direct contact information that's up here. Don't try to text that number; it won't work. That's a direct VoIP line, but that does go to the office in Baldwinsville that I haven't been to in over a year because COVID. But it goes to my home desk. It goes to my cell phone. Goes to wherever. And email is awesome as well. So, question: when ALS dispatch a demon call BLS, should ALS provider be documenting their ALS assessment on the BLS chart? I would leave that to be a agency requirement. All that's required for payment for ALS is the EMD code and then that drop down that an ALS assessment was completed. If the agency wants a an activity log entry of your assessment as the ALS provider, that's fine. Agency requirement though, it's not anything that's required for billing. So good question.
Jason, what are some of the common pitfalls, or what are some of the areas that agencies miss billing opportunities for? What are some of the highlights?
Really, really the big ones, the EMD codes. If you're an ALS agency, the EMD codes are huge. The ALS assessment's big. And then really just in the HPI really is painting the picture of what's going on with that patient and why we're there. HPIs are really this. I use this analogy a lot to explain it. Our chart's kind of like a Bible, right? It's got the New Testament and the Old Testament. The Old Testament is the HPI and all the stuff that the patient tells us. Back in the day, paper charts, the SOAP method, the subjective and objective, that's kind of where your HPI is at. What the patient tells us, what we found in the assessment. So that's all all that stuff up until page 8. So the document, the HPI, and then all those assessment tabs, page 4, 5, 6, all that stuff on EMS charts. That all helps to paint the picture. So you get a patient care report, and it starts out as a PCR, and it starts out as a canvas, and it's our job to paint a picture on it for somebody to look at and figure out what went on and why we were there, and we initially do most of that in the HPI and those assessment tabs. So having a good HPI of what the story is and what the pertinent negatives are is huge. And then the activity log of telling what we did and maybe, what we did and the reason why we did it is in that HPI. So those are really the two big things that I would emphasize over anything else as far as the meat and potatoes of the chart, on top of the EMD code and the ALS assessment.
We have some upcoming training with our training coordinator. We've seen a lot of charting recently that's very vague, and by being vague, that doesn't necessarily cover you. So we need to get a lot better with charting that stuff to begin with. So we're going to address that from a clinical perspective. But one of the other questions that I had was sent to me by one of the employees was caregiver roles. If you're familiar with EMS charts, where you have the drop downs under the names for caregiver roles, we've instructed everyone to do primary driver transport or primary caregiver transport for all roles. Is there any billing significance to that, or is that just agency preference?
Agency preference and NEMSIS. Each person's got to have a role assigned to them for NEMSIS, but nothing for us.
Okay.
Not so much the role doesn't really matter for us as much as the levels of care matter for us. Obviously, seeing it's an ALS chart, it's an ALS call, the primary care provider is an ALS provider. That's pretty helpful. But as far as assigning further roles like primary driver, primary, other, secondary care provider on scene or whatever. Not really a lot of significant stuff at all. So, Eric, I will forward to you a link that you can forward out to folks as well. Last week, 2 weeks ago, I was on the EMS Handoff podcast with Gems talking about documentation. So there's an hour of 4 EMS folks talking about documentation, and I'll send that link out if people are podcasty kind of folks, and that's something else that you can have as well. Any other questions? Unmute if you'd like. If you have anything else, or chat, or Daryl's got his hand up again.
The amount of attachments on a chart, does that affect the rate that you bill us?
Nope. Nope. The commission rate is the same across the board, with the exception of Medicaid, which has to be a fixed dollar amount. So that's it. None of that changes, regardless of if you attach the Iliad and the Odyssey to a chart. It wouldn't change anything, other than how long I have to scroll through it. That's it.
So I know a few times you've talked about getting dispatched to an ALS determinant call, so chest pain, things like that. If we go to a lift assist that turns into a transport and it's BLS, is that something that would be billed BLS regardless of there being an ALS provider on the ambulance?
Correct. Yep. So you can never upcharge technically, right? Even if you have an ALS provider. So you can if it's dispatched ALS and you assess ALS and you transport BLS, you provide an ALS service through that assessment, so you could charge an ALS. If you end up going and taking the patient BLS to the hospital on a BLS dispatch, it's still billed BLS even if you had an ALS provider present. They just happen to be in the role of driver on that particular call, just due to the way that your crews are put together. You could definitely, and we do it all the time, have a BLS call that's dispatched BLS and turns into ALS. That's fine.
Right.
But you can't have any kind of change with just because you have an ALS provider there. If that resource technically wasn't dispatched there, can't charge for it.
Gotcha.
If you guys end up taking the questions later, please feel free to shoot me an email, give me a call. I'll be more than happy to answer them. And someday, be more than happy to come out and do another, a similar presentation in person someday. That'd be great.
Well, this was really great information, Jason. Really, thank you for your time. And I think there's a lot of stuff here to digest. And if there are questions from the staff, I'll be happy to forward them on to you. It's great to have a resource for that stuff.
Yeah, happy to provide that. And it's going to take a while for this video to compress, Eric, so it probably won't be till after lunch when I'm able to send it to you. It'll come as a share file link, like most of our reports do come to you every month. It'll come the same way. That way, it's not a massive file. You could just click the link on it and download it. But it's gonna take a while to compress this. We've been going for an hour and 37 minutes on the recording, so it'll be a big file. So it's gonna take a minute to compress it. But other than that, I'll get it sent over to you. Any other questions before we wrap it up? All right, cool, guys. Thanks for your time today. Thanks for everything that you do every day, and stay safe and stay healthy out there.
Thank you.
Thanks, Jason.
Absolutely. Thank you, guys.